pressing record now, so that everybody's aware of that. And I will keep an eye on the chat for you as well, unless one of you has planned to manage it.
No, that would be great, Bettina, thank you.
So I'll do that. So I'm just about to make you the host, Errolie.
Thank you.
Okay, you should now see a little thing come up telling you that you're the host.
Hey, yeah. Okay, thank you.
Thank you, and good luck to both of you.
Oh, thank you. I think we'll need it today.
Thank you.
Okay, I'm going to share my screen in a moment. I just wanted to say hello to everybody and thank you for joining us. Jessica and I are going to be presenting this together, but you will have a kind of PowerPoint in front of you for most of it, and then we'll see our faces hopefully a little bit later. So let me just see if I can share my screen. That would be a good start. Hey, right now, can I see that from the beginning? Hey, there we go. Okay. So Jessica, over to you.
Okay, so that's just introducing us. I think I've tinkered with the title slightly from what we advertised. So it was about embedding recovery principles in the safeguarding process. And just to say that we're going to look at specifically around safeguarding to do with self-harm and suicidal thoughts, suicide ideation, and that both Errolie and I, whilst we are fairly experienced education practitioners, we're not setting ourselves up as any sort of expert around this, but what we wanted to do is share the experience that we have had of working with these learners who've experienced some of these symptoms, shall we say, and not to make people into therapists. So it's just a way of working that we feel we have in common, that we would like to share with all of you, that might be of some use. So just to make that point. Okay. We just wanted to do a trigger warning, because obviously we didn't quite know who would be here today, and sometimes discussing some of the content could be triggering for people watching. So what we've done is we've made all our signposting support material available on the Padlet to the event, so you don't have to wait till the end of the presentation to access that if it's needed. So just to let you know that some of the material might be a little bit triggering or a lot triggering. Hopefully not. We've been quite careful, but you just don't know because everyone's different.
Okay. So how we thought we would start this, we sent out a survey monkey to all of the community learning mental health projects earlier this week or last week, and we wanted to keep it very brief, but we kind of wanted to see what context we were in, as in how people felt about dealing with maybe learners that were disclosing self-harm or suicidal ideation. And this came up because of one of the questions that's on one of the tools that we're using at the moment. So in front of you, you've got the 5 questions that we asked. We were aware that depending on what your role is in your organisation and also how big it is, you may not know how many, on average, how many safeguarding incidents you have in your setting per academic year. But we thought we would ask, again, because it's quite interesting to see who knows what and how many people actually are involved in safeguarding. And then obviously the second thing was there an increase in the figure because of doing the mental health project? We also then asked how comfortable people felt about answering or dealing with question 9 on the PHQ. So just to remind you, question 9 is whether people have been having thoughts that they would be better off dead or hurting themselves in some way. And then we asked a question about training, and then also how confident people felt with that question and dealing with issues around self-harm. So our results on the screen now for you. Unfortunately, kind of what I thought might happen in terms of what we got. So the safeguarding incidents, a lot of people didn't actually know, probably myself included actually, how many incidents they have in their setting per academic year. And the range was quite staggering. We had some people that thought there were only 2, and then up to as high as 1,000 in an academic year. So a huge range there of what's happening across the country. The increase during phase 1, 50% of people didn't actually know whether that figure had gone up, which again is understandable. If you don't know what your baseline figure is, you're not going to know if there's a difference. And then 25% saw no increase whatsoever. and 25% did say yes, there was an increase because of doing the mental health project. PHQ 9, 40% of people said they actually felt reasonably or slightly comfortable asking that question of learners and dealing with the responses. 50% said actually they felt really uncomfortable, and then 10% skipped the question entirely, which I think probably comes back to being a little bit uncomfortable about the question. As for any training that had been undertaken specifically around those issues, 25% said yes, but actually a huge majority said no, that they hadn't undertaken any training specifically relating to self-harm or suicidal ideation. And that very sort of logically leads on to how confident people felt. So 20% said they felt fairly confident dealing with those issues, and a huge 80% said no, they didn't feel at all confident dealing with any responses that might come back from that question 9. Okay.
So just to quickly reflect, just briefly reflect, I think the thing that we were hoping to unpick, and I think we have a little bit around that, is that perhaps CPD is going to build confidence around that, and hopefully attending this webinar today might start that process. That's really the aim. Thanks. I'll go on to recovery principles now. Okay, so recovery is a concept around mental health services. So in education, we're kind of perhaps less familiar at working with it. They also use it as a principle in substance recovery, substance use recovery. So recovery is about building a meaningful and satisfying life. So recovering a meaningful and satisfying life, whether or not you have recurring or ongoing symptoms of your mental health. It's not about recovery in the sense that if you break your leg, it'll mend. I mean, that's a fairly basic example. Like, you know, nothing is the same really. So it's about recovering what is for you meaningful. And there are 3 key principles that I always keep in my mind, because it's hard to keep more than 3 in my mind. I always think of them as hope, opportunity and control. But as you can see on the side, we've got them as hope, opportunity and agency. And I'm reading from the bottom up because that's the way I've memorised the acronym. So if I do it the right way around now, agency, it's this idea of gaining a sense of control over one's life and one's illness. The opportunity to build the life beyond illness, and using non-mental health agencies, which of course education is one. Got the mute, Errolie, at all?
Yeah, I'm just trying to find it.
Sorry.
Participants, there we are. Yep, muted. Everyone. Okay.
Shall we say? And
you should be fine to go now.
Okay. Can you hear me now?
Yeah.
Okay, so the opportunity, basically community learning is an opportunity, let's summarise it like that. And hope, and the belief that a person can still pursue hopes and dreams even with the continuing presence of illness, and not settling for less and all the reduced expectations of other people. So it's about how we, when we have those conversations, embed agency, opportunity and hope. So it's kind of bringing things together. I mean, safeguarding, you will have a safeguarding process within your institutions, but as a practitioner, these are principles that you can use yourself with those conversations, I think. I don't know if that's going to come through, but that's kind of the aim. So can we go on to the next slide, please, Errolie?
Yeah.
Okay, I'm not going to talk through these because I think it's really boring if people just talk on slides. The presentation is available. I think Katina's put the link up for people. I think for me, I can't remember all this when I'm sitting down and having a conversation with people, but I can remember hope, opportunity and control, or hope, opportunity and agency. And these just unpick it a little bit. We got these from the Social Care Institute of Excellence. And it just gives you a bit more to that, but I don't think I need to talk about it too much. I think for me, the key ones are empowerment. You know, if I'm not embedding hope, opportunity and agency, then I'm not empowering someone. And the other thing is prevention, that when I'm having a conversation with someone, I'm contributing to prevention, hopefully. and also when I'm having a conversation with someone, and within the safeguarding process, that we're being proportional in terms of our response, particularly around that question 9. So I'm going to, can we move on again, Errolie?
Indeed. Okay, so I'm going to talk a little bit about self-harm, but again, I don't want to flood people with information, and as Jessica said, it's a bit boring to kind of just read off the slides to you. So I'm going to do a little bit about self-harm, and I'm in no way an expert. I need to make that very clear. These are just some thoughts and some research that I've done, and Jessica's then going to talk about the kind of suicidal ideation side of things. So I think the first thing for me when you're dealing with someone that's disclosing self-harm is to take it very seriously. But looking at the kind of statistics and the research that I've done about it, the majority of people who self-harm are not necessarily suicidal, and self-harm can be seen as a form of communication. Most people who self-harm will say or describe it as a coping mechanism. So it's a way of dealing with feelings. So if we can allow them to use a different method of communication, that can be nothing but helpful for them. So I have a quote on this slide here, which hopefully you can see, which is that you need to look at the individual and not the harm. And I think the danger is, by trade I'm a psychotherapist anyway, so I've worked with a lot of people that obviously are having issues around self-harm. So I know not to jump. But I think if you haven't come from that kind of background, there is a tendency for people to be shocked and to jump when people mention things like self-harm, like suicide. And I think it's very important that you try not to do that. So you look at the individual and not the harm. You look at the person behind the scars. You look at them as important, and the act is not as important itself. Obviously, it's serious, but we need to keep it in context. So in terms of how you establish a kind of constructive conversation with that person, you do need to build a rapport in the same way that you would with any learner. You need to ask how they're feeling, but allow them to talk at their own pace. It shouldn't be forceful. You shouldn't be demanding that they talk to you, but offer them the opportunity if they want to. Again, don't be judgmental, and that comes from your mannerisms, your tone of voice, the look on your face. All of that can convey a message of judgment. So you need to be very careful about how you are interacting with the individual. Let them know that you want to listen to them and you want to hear how they're feeling, and that you're actually okay with them disclosing whatever it is they're disclosing, and that it's perfectly acceptable for them to talk to you about it. Be compassionate, be respectful of whatever it is they're telling you. You may not understand what they're telling you, and that's absolutely fine, but you need to just be there to listen. And be aware that self-harming is only going to be stopped when that person is ready and able to do so. So there's a few strategies I've put on here, which again, I'm not going to go through massively because I think you can access the PowerPoint anyway, and I have got a list of organisations, which again, you can go to if you want some information. What I would say is, read up on the subject, find out about it for yourself. That's hugely important. But mostly it is about being available and being able to listen to that person as an individual and to empower them to make choices. So you are in effect trying to keep them safe by allowing them the opportunity to communicate about their experience, about what they're going through. So just a few more things to encourage them to talk. If you can help them to work on their self-esteem, that's even better. And these are some of the links that I was talking about. The important thing is, if you're not comfortable and you're not confident, is to understand that you're not a doctor, you're not a therapist, you're not there in that capacity. You are there really as a signposting and referral person. So it's about making sure that they've got access to the right support and to people that can offer them whatever it is that you can't. I think that brings me to the end. Just something I wanted to add, actually, that's not on the slides, but again, through some of the research I was doing, some of the service users' experiences that have approached safeguarding officers about this is just from learners across different settings locally. Their experiences, some of the negative ones, I found quite surprising. But again, I think it's because people feel uncomfortable. So some people felt like they were being told off, dismissed, or condemned a lot of them felt that they couldn't express themselves because of the fear and the shock that was displayed on the face of the person they were disclosing to. So that kind of shut them down. They then felt completely unable to talk about it. Also then being treated as if they were being irresponsible in some way and attention seeking. My personal feeling on the attention seeking thing, I can't bear that when people throw that out as a thing, because everybody seeks attention, and actually what you're doing there is judging the method that they've used to seek attention. Well, this isn't what it's about. If they want attention, the best thing you can do is actually give it to them, regardless of how they've asked for it. So that's the end of my section on self-harm. And now I'm going to hand back over to Jessica, who's going to talk a little briefly on, we're going to have questions apparently. Then we're going to go on to the suicide side of things. So are there any sort of thoughts so far on anything that's been said, or any questions from anybody?
I can see Anna's typed in the chat, Errolie. I don't know if Anna wants to speak her question, or I read it out. It says, Anna says that listening and seeing the person is key, and that she'd worked with someone who was self-harming through excessive gym use. So that idea of giving people your time.
Yeah, absolutely. I'm just going to see, I've unmuted Anna if you wanted to say something.
Oh, she says she can't speak in a public place.
Oh, apologies. Okay. Okay.
Are there any other questions?
Sorry, I was just going to say, I absolutely agree. I mean, Anna's just reiterated the point I'm making, really. It is about seeing the individual and not the behaviour. The individual is key.
Any other questions, or shall I press on?
I have one. When you sent, sorry, I didn't look. When you sent the survey out, did you define what confident would look like? You know, when they said they don't feel confident, did you define what confident would look like? No,
and that's something we're aware of. Because we had a short window of time to collect this data and also analyse it, we kept it fairly brief. So obviously, you know, they have to take
or you might need to mute all.
Yeah, okay. I'm getting there.
Somebody's somewhere very lively by the sound of it.
Someone's having a very good time. Let me see. Neutral, okay. Okay, hopefully that's a bit better. Yeah, we purposely kept the survey very brief because of the time parameters that we had. And I am aware that asking if someone's confident about something, you're going to get quite a vague response, because, as you say, confidence can look very different to different people.
What I was wondering, Errolie, is if people would type into the chat while Jessica's doing the next bit, just what confidence would feel or look like for them, because I think this might be, I mean, obviously we can't ignore the fact that now 80% of your respondents have said they don't feel confident around question 9 on PHQ9. We have to, you now have triggered my duty of care, okay? So we now have to do something with that, and so do those of you who are managers, you know what I mean? So I think what would be helpful, just as a beginning to help me think this through in terms of what it means that we have to do, is if people could just describe in just a few, you know, however many words it takes them in the chat. I think it's an unlimited piece of paper. What confidence would look or feel like for them, just to get some kind of sense of that. And I think that of itself may be important for us to realise that it means different things to different people, but it may be a good starting point. And then the bad news for you two is you've definitely created some work for yourselves, because you really have to do something about this.
I'd be totally willing to do, you know, a little workshop if people thought that would help them. It's something I do as a teacher anyway, so that would be absolutely fine. But yeah, I think that's a fantastic idea, because, as you say, the survey was minimal, purposely minimal, but yeah, it would be great to get some individual responses from people. Okay, so I'm going to move on now and pass back to Jessica.
Yeah, I just want to quickly reflect that the confidence is my word, because Errolie put a different word in, and I was worried that the other word would get fairly negative responses through, which didn't really give us anywhere to go with that. So confidence, and now Katina asking that good question allows us to unpick that a bit more. So, but anyway, hands up there. The other thing as well is self-management is one of the things that you're aiming for sometimes within recovery. So if you think we've got an awful lot of links and signposting, then recovery is individual to each person. and there isn't a one place to send people. You kind of need, you don't want to overwhelm people, but people need to know that there are different places that they can look at different times.
Yeah.
Okay.
Absolutely, yeah.
Shall I carry on?
Yeah, indeed.
My computer started hissing. Can anyone hear that? Can you hear the hissing?
Yeah, just a bit.
Sorry. Anyway, there's some good overlap with what Errolie has said. It's about establishing rapport, using the non-judgmental approach. I understand that it's really tricky. You know, we're not poker players, are we? If you feel under pressure that you're not to say something or not to do something, that just can make you sort of feel quite uncomfortable. So I think it does require some level of bravery to have the conversation. But I was very empowered by having the training a few years ago with a practitioner, and he very much said, I mean, he'd been a psychiatric nurse, a social worker. He said, ask, yes, go there, have that conversation because it's useful. And not just have the conversation, start a dialogue, which here says, ask some specific questions about that. You know, what are the thoughts? Yeah. Does somebody have plans? Because if they have plans, it means they've spent some time thinking about it. And the more advanced their plans are, the more in danger potentially they are. And I didn't want to get too much into it in terms of risks for suicide and protective, because there are protective characteristics for suicide as well. So, you know, some practitioners would, I'm not talking about education, but clinically they would make a judgment around that. But you could read about that. So, for example, if you've got somebody who has quite a few risk characteristics and not very many protective, you might be strongly encouraging them to take themselves to see their health professional, and you might be making a note of that on your own safeguarding process, that actually I've advised this person to go to A&E, which is what we do locally, or go to the GP, and can we follow that up within our safeguarding? Because obviously once you've filled out the form, it goes to the designated officer. Can I go on to the next one? Is that all right? Again, it's about trying not to minimise what someone's saying, hear what they're saying. I mean, at the very least, you can just listen. You don't want to make it better because you can't. You don't want to try and say things that, you know, could be, you know, could pass. Just listen. If you're not feeling confident, if you're not sure what to say, that's the best you can do, I think, is not listen and try not to show that you're, you know, it might be quite a shock, because actually it's incredibly, incredibly common. Many people with mental health issues have suicidal thoughts, unfortunately. And we've got a bit about learner voice now, which I think I'll go on to, because that will show you the other side of how that feels. So this was a learner I worked with who had quite a lot of risk factors for suicide. He's happy for this to be shared because he would like the more people to know, the better. That's what he thinks. He lost his son to suicide. And at the beginning he said, I remember showing my son's photo to the staff member and they just listened. They didn't jump in, try to, they let the person explain their situation. He said there was no trying to put themselves in my position or relating someone else's experience, because they would have then just shut down. So when in doing that on the first contact, you've established the rapport, and it means that somebody feels that this is, if they're struggling, that they can come and continue that conversation. That person was safeguarded and remains so today. The person says, I tend to look at the other person's face and see what reaction they show, which was really interesting. I just said, do you want to tell me how that felt for you? And this was a couple of years ago now, and this is what this person said. In other places, I don't know if they're going to react to the story or the effect that it's having on me, but if somebody gives out a feeling of discomfort, it always puts that person in a state of unease at the next meeting, so they're less likely to say how they're feeling, and they're less likely to disclose any further thoughts around that. So it kind of limits the opportunity for that prevention work, really. Now, I know it's tricky because we're tutors often, but these might be things that come up in IAG. And we had a good conversation on one of the webinars earlier this week about training first aiders in mental health first aid. So there's always somebody within the building that can talk to people, to learners that are having these feelings. But again, it's not about us having the answers, it's just about doing some listening, making a safeguarding referral, not jumping into the person's story, being proportionate, and allowing them, because at the end of the day it's their choice. So you know, the hope, opportunity, control or agency lies with them, so respecting that. Thank you, Errolie.
Okay.
So that's our last slide, isn't it? So there's lots of questions I can see now. Do people want to see questions? Or shall I read them out?
Let me have
I know I said I would, but I've been typing them a bit, so it would be better if you read them.
Oh, no. I'm going to mute all again just for a moment because there was a lot of feedback there. Okay, Jessica, you're unmuted. Okay, I'm just going to see if I can stop sharing this screen for a moment. Right, hang on. Oh, no, no, I'm not going to do that.
There's loads there answering Katina's question about confidence in very interesting ways.
Okay.
So it's Alicia says is about the confidence, having to go to somebody with the concerns, but it's the listening's okay. It's what do I do myself then, and the debrief, and I think we've not gone into that, and that really is part of it. Yes, so with safeguarding, and within that there needs to be something that happens formally or informally, but definitely happens to support the staff member, because you know it does have an impact. There's somebody, Graham says, knowing that you're giving the correct advice which will not cause more harm.
Yeah.
So I don't know what you would say. I would probably say you are signposting.
Yeah.
You're not advising as such.
Yes, I was going to say exactly the same thing. You're not really offering advice. What you're doing is offering information and guidance, because you're not in that role to offer advice really. But it is about, I think Jessica said it earlier, it's about having a range of information at your fingertips so that you can refer people on and give them choices, give them options, because every individual is going to be different, and they're potentially all going to want to access different types of services. So it is about having that information at your fingertips. But yeah, certainly I wouldn't suggest offering advice as such, because you're not in that therapeutic role.
Anna's asked, has this come up for you in your work? And I will say yes, it has, but I don't. And I'm happy to talk about that in a different forum, confidentially. But
Yeah.
If this is going out on the internet, I'm a bit worried about keeping confidentiality, just in terms of how I describe the situation. So I'm happy to take that forward, however that's felt best to do, really.
Yeah, I would agree with that.
Who else?
Jessica, if you want to do that now, we can stop recording if you like.
Oh, okay. If you